Hello, everybody. An absolute pleasure to be here. As introduced, my name's Eva Morris, and I'm a health data epidemiologist working out of the University of Oxford. What I do is I use the administrative data that flows through the NHS to look at patterns and outcomes of care. And I've always had a particular focus on cancer, and especially bowel cancer. I'm absolutely passionately enthusiastic about the data that flows through the NHS and what it can do to help transform care and improve patient outcome. But I also think we're missing a big trick at the moment in how we use that effectively, because there's so much concern about patient confidentiality and who can and can't access the data. So what I was going to do today was to give you an overview of what I mean when we talk about health data, and give you some examples of how we use it, and then talk about the risks of using it and not using it, and get some debate about what you think we should and shouldn't be allowed to do with it. So the main example I'm going to give is bowel cancer. And talk about that. Bowel cancer is a major public health problem in the UK. So it's the fourth most common cancer, and over 42,000 people each year are diagnosed with the disease in the country, with almost 17,000 deaths. 53% of people will survive up to 10 years, but what we do know is there's a postcode lottery, and where you live depends how long, can influence how long you live for after the cancer, and there are big variations in outcomes and who gets treatment. That's shown on this graph, which is a bit complicated, but this is a figure from the International Cancer Benchmarking Partnership Study, which compares survival rates between different countries with similar cancer data and similar health systems. And this is each different section on the graph is a different cancer, and the different arrows are different countries, and the UK is the deep red colour. And they've got different arrows on them, and each over time, they represent different time points. And the good news is, you can see from this, that over time, everybody's cancer survival is improving. The rates are picking up. But on each single graph there, we're at the bottom of the pack, or towards the bottom of the pack. So internationally, our survival is much worse than other countries. And we're not closing that gap in any way, shape or form. And this was data from 2019 to 2014, so a long time ago. We know now that the NHS is even in a lot of trouble. It's under huge pressure. We've had COVID, we've had all manner of different challenges facing it. And you don't have to go very far to see bad headlines about cancer waiting times and treatment and staff and resource. And so we've got a real problem. And how do we tackle that? We need to do something. And how can we do it cost effectively? I believe it's through data. And we should be able to do an awful lot, because we have a lot of data in the NHS. It's an absolute treasure trove of information. And there's all these different kinds of data sets that exist out there. If we could use them to work out where the NHS the blockages were, where people were struggling, where outcomes were worse, we could target our resource more effectively, be more efficient and have a bigger impact. But we can't, because there's lots of concern about research access to these data sets, because they contain patient confidential information. And it shouldn't be that we can just roam through everybody's medical record and look at everything that's happened to everybody. And we can't possibly consent everybody to do it, because we can't consent everybody in the country. But I think there's a bit of a misunderstanding about what we mean by patient data. And the public, and you may not understand what I'm talking about when we say that. So I'm just going to explain what I use. Now, every time you hit the NHS, a record is formed, and the information is coded. When you go to the GP, they take information about what diagnosis you've got, what drugs have been given. When you go to the hospital, equally, what procedures you have, who sees you, what tests, what operations, etc. And also there's even cancer registries, which every time a cancer is diagnosed in the country, information is captured in there about what cancer it is and where it's information about the date of diagnosis and how long you live for, etc. But these data are all separate. And what I use is these administrative data, and I piece them together. So here I've got examples from 3 of my friends, actually, who've all had bowel cancer. And I'm just showing you the kind of information that I use about them. I know these people very well, but you won't be able to tell much about them at all from their information. So this is person 1, female at 45, had a colonoscopy that found a cancer. They had an operation. They had 9 cycles of capecitabine. They had a CT scan and then 3 more of Folfox. Then they had a liver resection because the disease had spread to their liver, and then they had more chemotherapy. And that's their record. And all I get is the codes and the number of events. A male, 49, colonoscopy, another colonoscopy because the first one missed it, found a cancer, 2 lots of staging, an operation, and then they were fine so far. And then a person who's a female again, 51, colonoscopy, diagnosis, lots of CT scans, an operation, entered a clinical trial, lots of chemotherapy, and that gives the record. Now, I want to piece these together so I can look at patient pathways and then compare them in different areas, but it's really challenging to do because the data items are all held in different places. So the diagnostic information is all held in the hospital record, and the procedures. The diagnostic information is in the cancer registry, the imaging and the diagnostic imaging data set, and the chemotherapy and the systemic anti-cancer therapy data set. So they're all separate. And unless I can link them together, I can't really look at a patient's trajectory. So what we need are patient identifiers, and we really mean by that the NHS number. And if we can have that, then we can start to piece them together and link the events from different records into the same data set and be able to look at exactly what happens to people. What I'm not using is the detailed information that conversations you've had with your GP or your surgeon or anything like that. All I'm using is this coded administrative data. And this is hugely powerful, just that coding information. For example, when I first did just after I'd done my PhD, there was big concern in the colorectal cancer community and bowel cancer community that the abdominoperineal excision operation was being used too frequently. Now, this is an operation that has to be used for tumours that are very close to the anal verge, but it leads to a permanent stoma. About a third of tumours are in the lowest third of the rectum, and so they have to have this operation, but there's 2/3 of higher tumours could have a different operation, and that can maintain intestinal continuity. So the thought was that people were just using the abdominoperineal excision when they didn't need to, and loads of people were being left with a stoma when they didn't need one. But no one knew because we didn't have any data. So what we did was link the cancer registry data to the hospital data, and for the first time, we were able to look at the proportion of rectal cancer patients in each hospital, which is each one of these bars on this chart here, and the proportion that were having an abdominoperineal excision compared to other operations. And the blue area is the proportion of patients in each trust. And you can see there was considerable variation, and some were using the operation way more than 30% of the time. So we knew where to act and why was the variation, to go and find out what was going on and take action on it. We disseminated it. It kind of went a bit wrong at this point because it got lots of publication and media news, and it wasn't very necessarily all that constructive. But what it did show was that for the first time, the NHS could see what it was doing. It could start to monitor care and monitor pathways, and that was really important. And I really do believe it has a massive effect. So this is another study we did looking at post-operative mortality, the proportion of people that die within 30 days of surgery. And again, each bar is a different team managing these patients. And when we first started it, that was the variation across the country, and it was substantial. And then after we started publishing it routinely, and the team started talking about it and working out what to do, it all fell off. And that's a lot of people who don't die now within 30 days. And the variation is still there, but it's significantly reduced. So I think it's really important to be monitoring all the time what we're doing. And this really came to the fore during the COVID pandemic. At the outset of it, everyone was told to go home. I think it was very stay at home and protect the NHS. And everybody did go home to protect the NHS. And then we were given special access into the really rapid data that flows through the NHS. And we started to look at it to see that colorectal cancer patients weren't being diagnosed, but also that people were staying at home and having their heart attacks. And they were staying at home, protecting the NHS, not going into hospital and not receiving that life-saving treatment. So we fed this back straight into the government, and literally overnight, the messaging changed, and it went from stay at home, protect the NHS, to the NHS is open, come in if you need it. And that had an enormous impact, and the data are really, really powerful if you use them well. And then again, the Oxford BRC did an enormous amount through the pandemic to try and inform the NHS and help us and manage the pandemic. For example, the recovery trial was able to work so fast because it relied on NHS data to look at the outcome information rather than each doctor having to write down exactly what happened and report back in. And likewise, the vaccine. Not only did we develop it, we also deployed it and gave them the information they needed to make sure that most people at high risk got the vaccine when they needed it. So it's enormously powerful. And we hear all the time, this is an old quote, I should have probably got a more recent one, but we're hearing all the time that the NHS can capitalise on these data and we can use them and we can deploy them and we're going to be fantastic and we're going to do AI. But for me, it's proving very challenging because we can't get to the data to apply all those techniques. And I'll whisk through these. The potential is huge. You can do lots of different types of studies. I do lots of population-based studies and patterns of care, looking at diagnosis, who's presenting at GPs, looking at inequalities across populations. I do a lot of applied health research where we take the information back out to the hospitals, talk about why there's variation and try and introduce interventions to address it. There's loads of research cohorts out there, really, really rich data sets like the UK Biobank, Million Women Study, Our Future Health. Again, you link to the administrative data that flows through the NHS, you can enhance those. And then you can start applying the novel health data science techniques. There's huge talent in the Oxford at doing all these new things, AI, imaging, assessment, pathway mapping. The potential is limitless. But I'm going to explain to you one project that is very dear to my heart that is really, really struggling because of access to data. So this is a project that we published in 2019 looking at post-colonoscopy colorectal cancer rates, or PCCRC. Now, the main test to find a bowel cancer or a colorectal cancer is a colonoscopy, which is where you put a camera up your bum and have a look to see if there's any polyps or tumours there. But it's not a perfect test and cancers can be missed. Or not found, and so when that happens, it's called a post-colonoscopy colorectal cancer, and we want to try and tackle that and reduce those rates. So we published this study which showed variation across trusts, and we benchmarked it. Now, it's all very well showing the variation, but what are you going to do about it? And you need to know why they're occurring so you can tackle them. So we went out and we got another grant from Bowel Cancer UK, and we set up an audit. And this time, every time a cancer came into the registry, we looked back in the hospital record to see if there was a colonoscopy that could have found it sooner than it did. And if there was, then we classed that as a post-colonoscopy colorectal cancer and sent the hospital that did that colonoscopy, that didn't find it, a root cause analysis questionnaire and asked them to tell us why it wasn't there, why it wasn't found. And then they're quite rare events in a hospital on their own, but we were then able to pull that information into the centre and analyse it and look for trends about what was happening. We categorised all the tumours we found. I think it's over nearly 2,000 tumours that we found in this way. And we grouped them according to the World Endoscopy Organisation categorisation. But what really struck me was the really easy wins of how we can stop this happening. So 27.1% of the post-colonoscopy colorectal cancers were nothing to do with the quality of the procedure. It was down to problems with referral pathways and patient factors and booking factors and things like that through the NHS. The people didn't know they had to come in. There was something went wrong with the booking, so they didn't get the right notification, or a wrong decision was made somewhere along the way. Now that's 27% is a lot of cases, and it's so easy to sort those and stop that happening. I think it was about 23% were considered absolutely unavoidable. So there was, no matter what the NHS had done, those cancers would still have been there. But for the majority, they were either probably, possibly, or definitely avoidable. And in terms of harm, what happened when these cancers occurred when they didn't need to? In the majority, there was no harm, but in a substantial portion, there was minor harm. In 8%, there was major harm, and 8% of people prematurely died because the cancer wasn't found. And when we work it out across the population, we reckon at least 850 people, and that is a picture of 850 people, if we acted on these findings, could have their cancer either found earlier at a more treatable stage or even prevented, because colonoscopy can prevent the cancers by removing the precancerous lesions. And that would be £7.5 million at least saved to the NHS. Not to say the impact it has on these lives. Cancer is a devastating diagnosis, and 850 people is a lot. So we want to carry on this audit, but we can't because we're not. The NHS says it hasn't got the resource to keep looking at the data. And so we're saying, well, we'll be the resource and we'll do it. And they're saying, you can't because you're researchers and therefore you're not allowed to access the data. So it's very silly, in my view. And I think it's almost immoral that the NHS aren't doing this. If you look at another industry where data and monitoring is essential, it's the airline industry. A long time ago, going by plane was really, really dangerous, and lots of planes fell out of the sky and lots of people died, and it was a very dangerous way to travel. But then they started to regulate it, and now, if anything goes wrong, if a door blows off, if things fall off, they know about it immediately, and they pull planes out of the sky and go and check it, and everybody works together, and there's training, and there's teams, and there's constant auditing. And now it's a really, really safe way to travel. Those 850 people in England alone each year would fill at least 2 jumbo jets. So why is it okay for us not to be using data for the airline industry, but not in the NHS in the way that we should? And why aren't we? Well, we're not using it because we can't get access to it in the research community, or it is very challenging, and it has been for a very long time. And that's largely because of concerns about patient confidentiality. And they are really real. You know, you have to have really strict governance because we shouldn't just be allowed to wander around looking at patient records. There has to be a robust system. But the system that we have is confused, and it's unwieldy, and it's inefficient. As a researcher, you have to go to numerous different bodies to get permission to access data, and they often come to different conclusions about whether you're allowed depending on who you ask. There are different rules for research, service evaluation and audit, and I live in a difficult world because I live on that boundary between service evaluation and research, and they say, well, you know, where are you? And this all leads to lengthy delays and loads of bother. And then it becomes a really, really inefficient system. You know, all the research, this is a picture from someone in the audience actually, of how the hospitals are submitting their data in, and they get told they have to send data into the system so that people can use it. But it comes in from all different ways, and each hospital in Yorkshire actually estimates it spends £1 million a year trying to extract from its system the data items it needs to send in for reporting for cancer, and that just pictures it for one data set. And then when it gets into the centre, they have to do loads of data quality control and data processing and stuff. And then they have all a slot on the outside saying, please can we have some data? Please can we have some data? And it gets really complicated for them having to monitor it and send it all out again. And this is a figure from a paper that was published last year, just showing all the different demands on the NHS England to send those data through. And then, of course, it's really inefficient for all the funders because they fund project by project or programme by programme. And there's teams of people in each university for each project having to jump the same IG hurdles and the same ethical and legal boundaries to get into the data. And it's just a massive industry that doesn't need to be there. And this has led to loads and loads of projects trying to tackle this. And everybody's trying to tackle it in their own way. And they're all solving one little bit of the problem. So, I don't know, CPRD, Open Safely, ORCID and Q Research all help us with primary care. But lots of times you need primary care linked to secondary care. And so where do you go for that? SAIL, and there's initiatives in Scotland where they all sort it for Wales or for Scotland or for England, but nothing for the UK. And lots of studies are UK-wide. So we're putting loads of money into this, but never actually solving the whole thing. And this forces all the people into different silos. And so we're all working, everyone's developing specialist skills, but all in isolations. Of course, we absolutely have to take care because you hear all the time of really bad things happening with people trying to access data that they shouldn't and trying to look at the Princess of Wales medical record, and that can't happen. We have to have a system, but there has to be, for me, a better system than the one we currently have. And our current system is ruled by the Caldecott principles, and we're always, whenever we submit an application to access some data, we're always asked to make sure we adhere to them. But I think Principle 7 is one that's really often forgotten, which is that the duty to share information for patient care is as important as the duty to protect patient confidentiality. And I think we've got the balance in many cases wrong. They're more concerned about the risk of someone knowing someone's name than they are about the risk of something bad happening to somebody. And when we've explained this in public consultations, and people start to understand exactly what data we're using, that we're not going into their patient record and seeing exactly what their conversation with their GP, but just codes, then they're very highly supportive. And I think we need to be more transparent and convey better the data we're trying to use and why we're trying to use it. So in summary, I hope I've shown you that the NHS data have enormous power and massive potential to really transform NHS care, and that there are lots of things already underway particularly in our BRC, trying to use these data to maximum effect. But I'm not sure that we're working as effectively as we could. And I think if we could break down some of these boundaries, we could really have a step change in what we can achieve, like we did in COVID. And so I'd suggest a new system is required that involves a lot more collaboration and a lot more efficiency. So that was what I was going to say. I was now going to hand over to Andrea.
So I'll try to, over the next 20 minutes, to complement what Eva presented, initially with some context around the BRCs and what we do in Oxford, and then selecting a couple of examples. One, because I think the huge potential that Eva showed about the data is also to personalize treatment and tailor the intervention to the individual. And the second point is talking about this paradigm shift is also, Eva presented a top-down approach. I think it's important to have also a bottom-up approach. So first of all, a couple of words about the BRC, because it's a fantastic opportunity. The BRCs we have in Oxford, and of course, in Oxford we have some of the BRCs around the countries, but the BRCs now are the real engine for clinical research, especially because the focus is what we call experimental medicine, so try to understand the mechanisms behind what we see, which means we can really improve the treatment and bring innovation to clinical practice. So it's a fantastic possibility in Oxford to have two BRCs, mainly because we have two trusts. We have an acute trust, which is Oxford University Hospitals, and we have a mental health trust, which is Oxford Health. The mental health trust where I work, I'm a clinician, a psychiatrist. We do mental health. We also have some community services, but the main focus is mental health. And I'm here today with my hat of lead of the data science theme within the Oxford Health BRC. Each BRC is divided into many themes, each one focusing on some specific issues. In the Oxford Health BRC, we have anything from child, adolescent psychiatry to well-being, to sleep. There are many, many, many themes. As a data science theme, for us it's crucial to collaborate within our BRC, and I listed some of the themes that we work closely with in order to combine the huge potential of data with also, as I said, innovation and clinical transformation. But also for us it's crucial to collaborate with the Oxford BRC because, I mean, I'm very transparent in this. We have so many things to learn from the other specialties, the fields of medicine, because if you think of oncology, you mentioned oncology, vaccines, of course, it's far ahead. And we need to bridge this gap in terms of mental health, bringing the science into psychiatry and psychology. Of course, it's crucial also to have a link with the clinical research facilities where we recruit the patients in order to do the studies that we design in our BRC. And also, Oxford is unique for the wider Oxford infrastructure from the Big Data Institute to all the Wellcome Genomic Institutes and of course also the Center for Integrative Neuroimaging. But these local collaborations, I think, make sense only if we look at the wider picture, which is nationally and internationally. Across the UK, it's important to work with clinical and academic sites where we can really use the potential of the research to transform care across the country, especially because diversity and less privileged areas are fundamental for our studies. But also, it's a fantastic thing that happened recently. So all the BRCs together and also inviting other centers, because the BRC is a competitive process within the NIHR, but it's inclusive. And now we have this translational research collaboration for mental health and other disciplines. And also recently an opportunity from the government called Mental Health Mission, injecting money in order to not only do the research, but also bring this research into clinical practice. Finally, for us, it's crucial for the data science theme to have international collaboration because our ambition is to have a global impact. And for this reason, we are learning from other sites across the world. These are only the most recent one. We are working on others, but from digital health to genomics and other precision psychiatry approaches, we are really learning from the other people. Okay, so the data science is actually supporting infrastructure researchers to do projects, and this is a summary of some of the projects we are doing, and they focus mainly on what we call the combination of routine and clinical data to personalize the care of individuals with mental health disorders. And we go from risk prediction to getting the information at the very beginning of the illness of what are the biomarkers. That's the BBC study that we have here, also in specific periods of life, the microbiome, and so many projects. For the purpose of this presentation, I only want to focus on two of them, as I said, for Petrushka, which is an example of personalization, and Count Me In, which is the bottom-up approach. So why personalization? Because why are we focusing on what is the best treatment for each individual? Because the evidence says that this is the most important question that patients want to be answered. This is a systematic review published 10 years ago, but this is the top one question that patients ask to clinicians. What is the treatment of choice for my condition? Starting from this, we combine what is the innovation and, if you want, the digital power. And this is an editorial from an issue of The Lancet, one of the top journals in medicine, just a few weeks ago. And this is about a clinical decision support system with the alerts popping up in order to help clinicians in their work. And I think this is very interesting for the purpose of our presentation, which is we need smarter, more user-friendly, more interactive, and higher positive predictive value in terms to have clinically relevant outcomes. This is not going to substitute the clinician, but become a useful and non-intrusive tool to augment clinical work. So we can use technology to personalize treatment. That's the other point I wanted to make. The third point is Eva presented a very high-level top research, probably top research in the world, when you see the end product. I want to take this opportunity to go step by step and show you how long it takes to do this research and to take it to the patient. So this is when, actually, it's not real, the starting point, but it's a big achievement we did 6 years ago when we published in The Lancet a network meta-analysis about antidepressants for depression, something very relevant for primary care, which is, if any, the best treatment for depression, assuming the patient and the clinicians want to prescribe an antidepressant. It's called a network meta-analysis because you have this network of treatment. This is the evidence available, which is interesting because you see how well connected these treatments are, which means there are head-to-head trials comparing these treatments. And based on this randomized controlled trial data, we can produce this league table with, at the bottom, I know I'm very proud of this figure, but every time I show to the audience, it's very difficult to read. So bear with me. It's just to understand, at the bottom left triangle is efficacy, top right is risk of discontinuation of the treatment. And the key point of this slide is people said antidepressants are all created equal. We highlighted and bold the differences between antidepressants. They are listed in alphabetical order on the diagonal. And you can see that there are many cells highlighted and bold, which means that the evidence shows that antidepressants are not identical. There are antidepressants that work better than others or are more tolerable than others. So the question is, how can we link this evidence to the real-world patients? And this is where the NHS data can really help. This is what I'd like to show you in a second. Before we do this, we need another couple of steps. One big limitation of the league table I showed you is these are averages. This is the mean effect of a drug on a population of patients, but we treat individuals, not averages. So how can we use the data to personalize treatment? We can use the data only if we have access to the individual patient data. We know exactly, as Eva showed, what happens to that individual. And let me show you this is a real example from a study where, for depression, at the end of the study, the best treatment was A. However, if you look at Helen, fictional name, she's a female, very depressed, very anxious, very young, 31 years old, no family history of depression, and short duration of symptoms. If you look over 12 weeks, the improvement of symptoms, it's clear that C is the best option because you have the biggest improvement in terms of symptoms. For Steve, less depressed, same level of anxiety, older, with family history of depression and longer duration of symptoms, over the 12 weeks, B is the best treatment. So if we lump everything together as averages, we miss the trick and we miss the target of individual patient. But what I'm saying here is part of the entire truth, because doing this, at least in mental health at the moment, we can stratify the treatment, but we are not there yet in terms of personalization. There's another big domain, another pillar that we need to add to this system, which is individual preferences. Because if you take Steve and you ask Steve, what do you think about insomnia or nausea, sedation, tremor, weight gain? Tell me which are the adverse events you don't want to have. And Steve says, I don't want sedation, I don't want weight gain. And as a clinician, I can tell there's no cardiac risk, no hypertension, no QTc prolongation, it's fine. With the individual patient data, we can predict what is the best option from A to E. But for Nick, men with the same clinical and demographic characteristics, because his preferences are different, he doesn't want nausea, he doesn't want tremor, and he has hypertension, the ranking is completely different. One treatment which was fourth line becomes the first line. So as a patient, I'd like to have this rather than trial and error or being treated with averages. And this is what we did with Petrushka. So we developed, based on this data, we developed a tool to be used in clinical practice. Of course, what is the missing point is how can we translate this information into something which is understandable for patients and clinicians. It's called absolute risks, and this is where the NHS data can help. Because Petrushka is a combination of individual patient data from the trials, I showed you the network, plus the real-world data. Q Research is one of the examples that Eva mentioned. We have fantastic primary care registries, and if we use them, we can really understand and predict what is the actual risk of having a specific adverse events. I'll show you in a second. Plus the third pillar, the preferences of individuals. We have the web-based clinical tool, and we are now doing the trial. The tool is, I'll show you in a second, is of course hybrid, because after COVID we need to do things remotely, but it's adaptable, and at the moment is so popular that not only in the UK, the study is funded by the NIHR, but also in Canada and Brazil, they are doing the same study, and they are self-funding Petrushka. Petrushka is password protected, so according to GDPR, it's compliant with the regulation, but the key thing is to ask patients which are, out of 10, the 5 adverse events that you don't want. This is the first step. Second step, once you have selected the 5 adverse events, can you please rank from number 1, the most you want to avoid, to number 5, the least you're bothered about out of the 5 important. And the next step is, if the top one is 100 points, how big are the differences between the first, the second, the third, and so on? All this was developed with patient representatives across the UK. And we end up with a TripAdvisor-like score, because this is what the patient wanted, an image, not numbers. But you can see top one is probably the best. This is quite similar, and this is clearly less effective. But that's the most important thing, and this is the contribution of the NHS data. We can predict for that individual that the actual risk of having headache if they take antidepressant 1 is 20%, for sleepiness is 6%, and so on. So we can really inform the treatment decision-making process in a shared way. The next step, and this is the funding we hope we will get soon, is to add to the clinical and demographic predictors genetic information. Because again, this is part of the gap we have with the other fields of medicine. So if we manage to include pharmacogenetics and possibly also polygenic risk scores, we will be able to do something even more precise, more personalized. And the study will be run not only in the UK, but also in the Global South, in Nigeria and Pakistan. Okay, the bottom-up approach, and then I'll finish. What we showed is the potential of the data. We need to have access to the data. We need to link the data. But the other big problem we have is taking part into research, and especially mental health. We, as clinicians, we tend to have a very paternalistic approach, preventing patients from accessing research opportunities. And I have to say that the clinicians as gatekeepers is one of the big problems we have that will stop and prevent people from taking part into research. The second point is because research is done in academic centers and they are basically happy when they reach the number of patients they want for the trial, we have evidence to show that the system as it is now is less equitable. So we need to improve all this. And what we think, based on studies that we have done over the last 5 years, is moving from an opt-in to an opt-out approach is the best way to make the UK and the NHS a place where people get better treatments, because taking part into research is associated with better outcomes. It's a way to make research more inclusive, also to empower patients in their decision about research. It has to be embedded in the NHS electronic health record system because it's an information which is live. And of course, after what we have done now, we have a group of centers across the UK and internationally interested in Count Me In. The name comes from a work we have done with patients and comms representatives. These are some of the publications, just to show that in all the publications we emphasize the role of the NHS, because otherwise the risk is to leave this kind of studies to the insurance registries. They are not real patients. We have a population registry, an opportunity which is unique in terms of richness of data and also the long-term follow-up. So very quickly, that's the second last slide, to show in only 12 months we piloted the project and we had 22,000 people available. They consented to be part of the Count Me In cohort, and only 1.6% said no, mainly because they mixed Count Me In with the national opt-out. We can come back to this during the Q&A if you want. Of those 22,000, 738 were contacted for a specific study and 270 actually entered the study. And that's the problem. We don't have enough enough studies to offer to patients. We need to increase the offer because we have a huge potential in this Count Me In cohort. The data show that the Count Me In cohort is more diverse and also it's very favored by patients and clinicians. But we need to improve in terms of inclusivity, as I said, and also engagement. We need to incentivize research participation. So to finish, and I echo what Eva said, adding that we need this shift in the NHS culture, and we also need to fill this implementation gap. And now, historically, is a great moment, not only because all the BRCs are working together, all the trusts are trying to put resources together, but also we have national initiatives. I mentioned here the mental health mission, but there's also a mission for dementia, for addiction, which is an opportunity to make the UK a place where people can really take part into research and have better outcomes. Thank you.